We will talk about renal transplant recipient medical evaluation. And Dr. Saeed Malik, our clinical director of transplant surgery, will be talking about the surgical evaluation. I truly believe that this is one of the most challenging tasks of transplant nephrologists, because we are always asked to make decisions based on predictions. And to be able to do that, I like to put things into perspectives. And I always start this talk by answering three big questions in transplant. Why we're doing that? Why we're sending our patients to kidney transplantation? Is there any benefit of doing that? When is the right time to refer our patient? When is the right time to transplant our patient? And what type of allograft you want to give your patients? So we'll start with a question. A 71-year-old female with ESRD secondary to presumed hypertension comes to your transplant center for pre-transplant eval. She has no potential live donors and would like to be considered for the deceased donor kidney list. She wants to know if there is any survival benefit for her to be transplanted compared to going on dialysis. Which one of the following statement is correct? Patient should not be considered for transplant given her age, as her chances of receiving a deceased donor transplant are poor. Patient would benefit from lower quality kidney to come off dialysis sooner. Lower quality kidneys increase mortality post-transplant and should be avoided in this case. Her chance of receiving a good quality kidney increased with a new allocation system. There are few patients her age on the wait list, so she will be transplanted very quickly. So unfortunately, it's not up, the system. Okay, so I'll go back to this question after I try to answer those important questions. So why choosing kidney transplant? Why sending our patient for kidney transplantation? Well, many studies so far showed a survival benefit of transplant compared to remaining on the dialysis list. I chose this study in particular. This is a Peter Abt group from UPenn, where they not only looked at patients receiving their first kidney transplant, but also looked at patients who received their second or third kidney transplant, patients who are receiving kidney transplant after heart, lung, or liver. And if you see here, all groups had better survival when compared to the waiting list that here in the solid line. Only patients that did worse are kidney transplant after lung. However, when they compared those people to the lung transplant patient on the wait list, they had survival benefit. So across the board, there is a survival benefit of doing transplant compared to remaining on the dialysis. And I wish that was that simple. So this is a very important study. I spent a few minutes discussing with all patients that are coming for transplant eval. So this is looking at ESRDS data, 250,000 patients who were started dialysis in the US, and they compared the relative risk of death for patients who were transplanted for that period of time to patients who remained on dialysis. The relative risk of death here, one, is the patients on dialysis. There was threefold increase in mortality for patients who goes to transplant compared to staying on the waiting list. And this is due to the perioperative risk, obviously. And then this relative risk start decreasing, becomes equal around 106 days, but the survival doesn't become equal until 244 days to compensate for the early increase of mortality. So, in other words, patients have to wait more than 244 days to start benefiting from transplant. And this is even, this line will shift to the right if we're talking about elderly patient, about diabetic patient, about Asian or Native American, which means that they will have higher relative risk of death and also will need longer time, up to 2 years for diabetics, to start benefiting from transplant. So this is why we do this thorough evaluation to really know which are those patients that had higher mortality early on, either to remove them from the list or modify their risk factors before they move to transplantation. And this is the same study, but in this case, they looked at, so what if we give those patients a lower quality kidney compared to standard criteria kidney? And you can see here that the line shifted to the right. So if you give lower quality kidneys to patients, they have a higher mortality early on, and they take longer time to really equilibrate their survival with, compared to staying on dialysis. So when is the right time for kidney transplant? So many studies show that early referral saves lives, and early transplantation saves lives. I chose this study in particular because in this study they did they looked at 2,500 kidney pairs, which means one kidney from the same donor went to someone who was on dialysis for less than 6 months. The second kidney from the same donor went to someone who's been on dialysis for more than 2 years. And look at then you eliminate all the bias that come from the donor quality kidneys. And then look at the difference in survival. There is a significant difference for allograft and patient survival for patients who've been on dialysis for less than 6 months. So there is a solid data that early transplantation is a good idea. So what type of kidney we should give our patients? So I showed you this data that if you use marginal kidneys, you increase mortality of patients, and they take longer time to start benefiting from kidney transplantation. So why would even offer lower quality kidneys to patients? And so the idea is to give those lower quality kidneys to patients who will benefit more from coming off dialysis sooner. So who are those patients? So if you look at this study by Meyer-Krish, patients older than 65 years old, they had higher chance of getting deactivated from the list, either because they died or because they developed some complication. And this increase over time. So the longer they are on the dialysis, on dialysis, the higher chance they will not getting transplanted. So those are the patients that probably would benefit from lower quality kidneys to come off dialysis sooner. And this is a very nice study by Meyer-Krish. By a sophisticated statistical analysis, they calculated the projected life expectancy for patients, whether they receive a lower quality kidneys, but they come off dialysis sooner, or they stay for longer on dialysis to get a better quality kidneys. So look at the projected life expectancy for a young patient, 18 to 39 years old. The life expectancy, if you agree to a lower quality kidney just to come off dialysis in 2 years, is around 17 years. If those patients wait until 4 years to get a better quality kidney, their life expectancy is more than 25 years. So it's not a good practice to give lower quality kidneys to young patients. However, if you look at the 65-year-old patients and plus, so if you give them a lower quality kidneys to come off dialysis sooner, their life expectancy is around here, a little bit more than 5 years. If they wait 4 years to get a standard criteria kidney, their life expectancy is not better, and in some studies was even lower. So those are the patients that will benefit from getting a lower quality kidneys. And this is where we got we give older kidneys to older patients. However, if you have diabetic patients, this is completely different. So if you look at the young diabetic patient, their life expectancy, if they come off dialysis sooner to get lower quality kidneys, is around 10 years here. If they wait 4 years to get a good quality kidney, their life expectancy is a little bit lower. So, for diabetics, still they would benefit from coming off dialysis sooner because of their higher mortality during on dialysis, and even if they get lower quality kidneys. So I'll go back to this question. Which one of the following statements is correct? This is an elderly patient coming for transplantation. Patient should not be considered for transplantation given her age, as her chances of receiving a deceased donor transplant are poor. Now, the age is no more a contraindication to transplant, so this is not correct. Patient would benefit from lower quality kidney to come off dialysis sooner, and I think we have enough data to back this up. So B is the correct answer. Lower quality kidneys increase mortality post-transplant and should be avoided in this case. That's true, lower quality kidney, there is an increased mortality, but again, they belong to, they should be given to patients who would do worse if they stay on dialysis. Her chances of receiving a good quality kidney increased with the new allocation system. That's not true. It probably decreased. There are a few patients her age on the wait list, so she will be transplanted very quickly. We have more and more elderly patients on the waiting list, so this is also not true. So I think Medicare has enough evidence to refer all patients to, for medical evaluation for transplantation. So when do you refer patient? You should refer patient early on in the process when their GFR is below 30. Now is more and more important because when the GFR is below 20, those patients can be activated on the list and they can start gaining time. And this is new with the new allocation system. So this is a mandatory practice. And then finally, this is the earlier we get patients to transplant, the higher the chance we teach them about transplantation, and there's a lot of data to show that this will improve their outcome. So my 3 rules of recipient evaluation: first, do no harm to the individual patient. So the last thing we want to do, take someone who's stable on dialysis and give them a kidney and make them do worse. First, do no harm to the list. So every time we give someone a kidney, we're taking this kidney from someone else, and we have an obligation to the list to do the right thing here. And obviously, do no harm to the donor. So the purpose of the recipient evaluation is really to identify risk factors that absolutely prohibit transplantation, and the list of the absolute contraindication for transplant is shrinking with the better medical care we have now. And a great example would be HIV patients. Now with the great heart therapy we have, HIV is no more a contraindication for transplant, but also to identify risk factors that can be modified to improve the outcome of those patients before they go to transplantation. So this is a multidisciplinary approach. We have a medical, surgical, social, and psychological evaluation that happen at the same time. Most centers now adopt one-day evaluation where all these specialties will be incorporated in one day. And then it's a very good time for patient to educate patients about transplantation and also answer that question and see what their expectation about transplant. And at this, we take the time to discuss donor options because now we have the KDPI score and the quality kidney. So this is the right time to teach patients about what is lower quality kidneys, why they would benefit from lower quality kidneys, what are the high-risk kidneys, high infectious risk, and would they benefit from being listed or not. And then it's also a great time to plan immunosuppression. You don't want to do those decisions in the middle of the night when you get called for a transplant. So another question, which of the following is not an absolute contraindication to kidney transplantation? Active malignancy that shortens life expectancy, active substance abuse, chronic illness that shortens life expectancy to less than 1 year, HIV positive patient, and controlled psychosis. So, obviously we talked about this already. HIV patients, this is no more a contraindication for transplant. All the others are now still contraindication for transplantation. So again, we start by what are the contraindications. Again, the list is shrinking, as I said. And chronic illness that shorten life expectancy to less than 1 year is important. And I told you in this study, patient needs to live more than 1 year to start benefiting from transplant anyway. So this is why, you know, we choose this 1 year as the goal. Active infection unless effectively treated before proceeding. Active malignancy that shortens life expectancy unless cured and remission is certain. Active GN, and some centers mandate that those patients, after treating their GN, to wait on dialysis for 1 year before they get transplanted. Uncontrolled psychosis, active substance abuse, and we mandate like 6 months of abstinence and a very close follow-up with a specialist before we reactivate them on the list. And obviously, severe obesity is a relative contraindication, and Dr. Malik will talk about this later. What is true regarding kidney transplant in patients with FSGS? Kidney transplantation should be avoided in familial FSGS because of the high rate of recurrence. Living-related donor transplant should be avoided in primary FSGS. Rate of recurrence in primary FSGS is up to 75%. Rate of recurrence in primary FSGS up to 75% if the first transplant is lost for recurrent FSGS. Who would go for A? Nobody want to show hands. B, C, D. Okay, so the answer is D. The rate of recurrence of primary FSGS is, you know, lower, between 30 and 50%, but it becomes significantly higher when you know, the patient lost their first kidney for FSGS. The familial FSGS, though, is, you know, the rate of recurrence is very, very low. In fact, initially we thought that this doesn't recur because the disease is contained to the kidney. However, now we know that some mutation, they may recur after transplant. So we approach the medical evaluation by system. So we do a thorough history, physical, and then we do a test as needed. So I'll start with the cardiac eval because, I mean, this is not only because of the perioperative risk we have post-transplant, but because, you know, our patients still, they still die from, you know, this is the first cause of mortality in post-transplant. And this is mainly related to all the risk factors that accumulated over the years, but also the immunosuppressant we saw them on that increase all the risk factor for coronary artery disease. You know, there is a lack of evidence-based guidelines here, but you know, the most widely adopted approach is to use a stratified risk, which means we do history, physical, EKG, and chest X-ray on everyone, and we move to more screening tests as needed. So, but the question is, what are what are the screening tests to do in those patients? So the American Society of Transplantation recommend coronary angiography only in patients who had positive stress tests. However, this approach was challenged over the years, especially knowing that you know, the non-invasive testing in our population has very low sensitivity. In some studies are below 50%, which they are worse than a coin toss. This is a good study by De Lima from Brazil, where they evaluated 120 patients for transplant. What they did, all these patients had a coronary angiography. Those are moderate to high risk patients for coronary artery disease. And all of them, either they got a scintigraphy or they got a dobutamine stress echocardiography. And whether they had normal or abnormal stress test, a non-invasive stress test, there was no statistical significant difference in the cardiac event they accumulated over the coming 5 years post-transplant. However, only if they had coronary stenosis on their coronary angiography of more than 70%, that this is really predicted cardiac event post-transplant. So this is why we have low threshold to send those patients for coronary angiography. However, I mean, it's still debatable whether, you know, even if you fix those lesions, if you would change the outcome of those patients. But, you know, the widely approached, you know, this is I think most centers now agree on. If the patients are have a moderate risk for coronary artery disease. If they are asymptomatic, we get a non-invasive testing. If they are symptomatic, then when we go obviously directly to a coronary angiogram. But if you have a high-risk patient for coronary artery disease, like diabetic for more than 25 years, or any of those two risk factors, then they should go directly to coronary angiogram. So the 6-minute walk test, part of the cardiac evaluation is to evaluate the functional status of our patient. And then most of the time we just do it by asking them how many blocks they can walk, and you can imagine how subjective when it comes to their functional status. So this is a very simple test that we usually adopt, and so you just need a hallway, and then you can ask the patient to walk for 6 minutes as fast as they can, and you see how much they were able to walk. And in this study of heart failure patient, if they walked less than 300 meters within those 6 minutes, their mortality in the coming 5 years is significantly high. So, this could be a good predictor for how they're going to do after transplant. So obviously, you want to look for infections in those patients. We're gonna immunosuppress them, so you want to make sure that they don't have active infection, and a special consideration for diabetic patients. I mean, many people would be burned by the a missed diabetic foot ulcer that's infected, or a osteomyelitis in those patients. So you have to make sure in diabetic patients to check for those before you transplant them. And those are the chronic infections that we look for, but again, as I said before, those are not absolute contraindication for transplant, but we need to do some extensive workup before we activate them on the list. HIV, Hep B, Hep C, TB, and CMV. And we only do those more extensive testing if the patients are from endemic areas. So there are general rules for immunization. Post-transplant, especially the 6-month post-transplant, you won't get any titers if you vaccine your patient. So you really need to give this vaccination before transplantation. And even ESRD patients, they don't really develop a good immunity to vaccines. So we need to do it as early as possible in the process of the disease when we diagnose them with CKD. And then, as you know, live attenuated vaccines are usually contraindicated. So this is very important to know. Those are the vaccine. This is what we ask for in our patients, and then you may be asked about that in the board. So malignancy. Obviously, the major role of the immune system is to recognize new antigen they form on cancer and to attack those cancer and to eliminate them. So when we immunosuppress our patient, they're at higher risk for de novo malignancies, but also for recurrence of malignancies. So we need to screen, make sure that they don't have any active malignancy. But what most of the centers recommend now is just age-appropriate screening. And if any cancer is diagnosed, you treat and you need to assure cure. And then there is a waiting time after that. And this can vary from no waiting time at all in situ cancers to like 5 years in melanoma, for example. So now for multiple myeloma patients, the rate of recurrence post-transplant is almost 100%. So most centers now, unless those patients has a bone marrow transplant, do not transplant myeloma patients. So for the hematology workup, we do the usual coagulation studies for everyone. We only do the more extensive hypercoagulable workup for patients who are at risk. Patients who had history of thrombosis, patients who had recurrent dialysis access clotting, and it's very important to do an access history on those patients, and history of spontaneous abortion. But again, this is not an absolute contraindication. What we need to do, we need to start those patients on anticoagulation peri-op. Patients with cytopenias and thrombophilias, usually we send them for a very extensive hematology workup with our colleague. So for renal evaluation, I think access history is very important. as I told you with the hypercoagulable workup. If the patient are not making any urine for a few years, you need to refer them to urology to make sure they do bladder testing, bladder capacity testing. Big part of what we do is predict the time for needing renal replacement therapy, and this is very important. We need to give the patient an estimate of their risk of disease recurrence. And this obviously, as we saw before, it depends really at what age they get they develop the GN and what is the rate of progression. And if there was a diagnosis, if they had a biopsy or not before. So I'm going to move to this. This was shown by Dr. Sidlaki earlier. This is the best study we have on GN recurrence. This is the 1,500 patients that were diagnosed with GN in Australia. They were transplanted and they were followed for 10 years. Patients with membranoproliferative GN and FSGS are the patients that not recurred the most but lost their graft most frequently. IgA nephropathy patient, for example, they almost always recur in most of the studies, but losing the graft from IgA is much less. So for cerebrovascular evaluation, it's mainly the same as the general population. In patients with seizure disorders, usually we try to send them to our neurologist to try to take them off any medication that can interact with CNIs. The same for pulmonary evaluation is, the workup is the same as the general population. We do pulmonary function tests for smokers, and if there's any symptoms of obstructive or restrictive lung disease, everyone get a PPD test and chest X-ray, and we treat with INH when indicated. And we advise all our patients to stop smoking. In fact, some insurance companies won't pay for transplantation if the patient is actively smoking. From a GI perspective, I think, again, the same as the general population, a specific emphasis is on the Hep B and Hep C. But because now we have so much effective therapies for both, I don't think that those are any more major problem. For Hep B patient, we either adopt a prophylactic approach or a preemptive approach. And this is where, at the time of transplantation, we start them on the antiviral therapy, or we follow viral loads, and if we detect any virus, then we start them on therapy. For the Hep C patient, we do usually liver biopsies, make sure they don't have any cirrhosis, and then now with a new therapy, I think we have a very good chance of treating those patients after transplantation. And the psychiatric evaluation is obviously very important. Everyone get a psychiatric eval. Just mental retardation is no more a contraindication if the patient have a good support. Compliance is a big thing, and patients need to show compliance before they move or get activated on the waiting list. And we talked about the substance abuse. So I'll finish by this, talking about transplant for special population. We talked about HIV patient. It's no longer an absolute contraindication, and the outcome of those patients is very close to the general population. So we transplant HIV positive patient if their CD4 count is more than 200, but they need to be stable on heart regimen for at least 3 months with undetectable viral load. Contrary to what you think, those patients basically have higher rate of acute rejection. The reason is because we most likely give them less immunosuppressant, knowing that they have HIV, but also most likely because of the interaction between the heart medication and the CNI. And it's not unusual to have patients, with HIV and transplanted on Prograf, for example, twice a week. So, which translate in a lower area under the curve, and this may be the reason for acute rejection. Heart transplant patients, obviously, we're always called for patients with heart failure who develop acute kidney injury or acute on chronic, and the question is always, should we give them a kidney with the heart? And sometimes it's very difficult to answer this question, and sometimes we proceed to a kidney biopsy to help us with the decision. And again, finally, for elderly patients, there is no limit for age at this point, but those are patients who are at high risk of over-immunosuppression, so we use usually less immunosuppressant with those. And those are the patients also that will benefit from ECD kidneys or a lower quality kidney with KDPI more than 85%. I'll stop here, and I will ask Dr. Saeed to talk about the surgical evaluation. Thank you.
Good afternoon, everyone. So I'm the clinical director of transplant surgery at the Brigham, and I'll talk about some of the surgical concerns that you may have while doing the preoperative workup of these patients. So basically, these are some of the issues that most commonly come up in the preoperative or the pre-transplant phase: obesity, peripheral vascular disease, urological issues, patients with prior abdominal surgery, where to put the kidney in, when they've had a previous renal transplant, and when do you need to do a native nephrectomy. So obesity and transplant. So let's say you have a 55-year-old female with end-stage renal disease secondary to IgA nephropathy and a past medical history significant for hypertension, sleep apnea, and morbid obesity. And she presents for transplant workup, BMI is 39.5. Which of the following statement is true? She's not a candidate. Her high BMI is associated with decreased survival, high BMI associated with decreased risk of delayed graft function, high BMI associated with increased risk of wound infection, or all of the above. So A, anyone for A? B, C, D? No hands for anyone? And E? Most of them are E. Well, let's see. So the answer is D. High BMI is associated with an increased risk of wound infection and delayed graft function. So body mass index is the most widely used marker of obesity despite its limitations. And the impact of obesity on outcomes after renal transplant has been controversial. For obese patients overall, registry data has demonstrated a significant survival advantage for recipients of both deceased and living donor transplants compared with remaining on dialysis. However, recipients of deceased donor transplant with BMI greater than 41 had no survival benefit. Wound infection, delayed graft function, and weight gain are more common in moderately and morbid obese transplant recipients, although patient and graft survival are unchanged. An analysis of 27,000 patients from the database showed that with normal weight patients, a BMI of greater than 35 was independently associated with increased risk of delayed function, prolonged hospitalization, acute rejection, and decreased overall graft survival. So that was one study. Then there were two other studies, and both of these folks, they looked at the same data and came up with slightly different conclusions. So a recent analysis by Nicoletta showed that for obese transplant recipients today, graft and patient survival is the same as that of non-obese patients. And then LaFranca looked at most of the data that Nicoletta looked at, and what they showed was that they recommended that in ESRD patients with a BMI of greater than 30, they should preferably lose weight prior to transplant. And if this cannot be achieved by lifestyle modification and dietary measures, then bariatric surgery should be considered. So this leaves us as, so what is the right thing to do, with obese patients? Should there be a cutoff? Should there not be a cutoff? So most transplant centers don't have a cutoff. Some do, but ours, for example, we don't have a mandatory cutoff that we won't see patients or we won't transplant patients greater than 35 or so, or 38 or 40. We will look at the patient. So if you have a female with a gynecoid pelvis, white pelvis, and she's otherwise healthy, no comorbidities, you examine her, you feel that technically you will be able to do the surgery and put the kidney in. Yes, she'll be at increased risk of wound infection, but you can go ahead and do the case. As opposed to a 60-year-old male with type 1 diabetes, peripheral vascular disease, has an obese abdomen, a pot belly. His BMI may only be 38, but technically it may be impossible to put the kidney in. So we base our decisions on our physical exam and on what other comorbid conditions the patient have, and don't set a limit. And I believe this is what most transplant centers are doing. Although some will say, no, if it's greater than 35, we won't take, or if it's greater than 40, don't. Most will generally turn down greater than 40, because if they're greater than 40, technically it just becomes very difficult, and they will recommend some form of either lifestyle modification to lose weight or a bariatric surgery. So in the past, gastric bypass was an option which very few patients wanted to pursue because of significant complications. But now with the lap banding, it's much more, it's associated with less complications, so more patients are willing to undergo that than the bypass. Peripheral vascular disease is present in about 15% of patients starting dialysis, and it is associated with increased mortality, although stable PVD is not a contraindication for transplant. Patients with bilateral severe occlusive disease not amenable to correction are not candidates. So if you have someone with severe plaque in both their external iliac arteries with narrowing symptoms, they can't walk at all, then obviously it's going to be difficult to put the kidney in and sew it to the iliacs. So either they are not candidates, or they have to have a vascular exam and have bypass grafts to the leg and then be considered an option. But usually patients who have this advanced disease also have other problems, usually have bad cardiac disease and diabetes, and generally are not in a condition to move ahead with a transplant. So what you do is you do a history and physical, you palpate peripheral pulses, you perform Doppler studies, and you can do an MR angiogram or a CT angiogram. This is a little tricky because many of them will be pre-dialysis, and then you do a CT, you can't use contrast, or you don't want to use contrast, and that doesn't really then give you a good idea. It'll tell you about calcification, but it won't give you a good idea about stenosis. You can do an MR, or you can do a vascular ultrasound and Doppler studies to help you. GU disease, the incidence is low, and if they are present, you need to get a urological consult. So if you have a patient who's been on dialysis for 8 years, doesn't make any urine, it's a good idea to send that patient to the urologist to do a cystoscopy or do some bladder studies, because sometimes you get surprised. You take them to the OR and you find their bladder is so small you can't plug the ureter in, and then now you're stuck. So it's better to have these patients looked at by a urologist before. If they have a dysfunctional autonomic bladder, they may need self-catheterization. That comes with the increased risk of infection, so you have to inform them about that. If they have a really small bladder, then they might need bladder augmentation or urinary diversion. And thankfully, those are rare occurrences, but when they happen, it's complicated, and it just makes life very difficult for these patients. So they need individual assessment, cystoscopy, voiding cystogram, retrograde pyelogram, and urological surgery. When do you do a native nephrectomy? So we don't normally perform routine nephrectomies except in pediatric patients. And the reason why they do them in pediatric patients, really small pediatric patients, is that most of these children, they are still making some urine, and the cause of their renal disease is urethral valves or reflux or something. And what happens is that if once they get a transplant, they start producing so much urine that it's difficult for them to keep up with the intake. So pediatric surgeons will recommend native nephrectomies in really small children who have still got a high output. Otherwise, basically, for adults, we take the kidneys out if the kidney is massively enlarged, so there's no room to place a third kidney, so then we would take one out. Or if there's a concern for infection, it's Staghorn calculus with repeated urinary infections, pyelonephritis, then we would remove that kidney. Prior to transplant, if possible, sometimes if the patient is pre-dialysis, then you have to remove it at the time of transplant. And that's basically all I have about the surgical issues, and thanks for your attention. Thank you.